let's get started, Anthony. I'm Dr. Singh.
I'm Anthony Meddock.
All
Hello,
right.
everyone.
Yeah, Dr. Medak to all y'all. Well, welcome to this version of our ultrasound course. A few big changes for us. I know this is new to all of you, but we're actually going to for the first time kind of combine with Palm, so it's a little bit different for us. Ultimately, we think that the course is going to be a lot better, and we think it's going to hopefully go very well with what you learn in Palm today, and kind of go hand in hand. For today's first session, we're going to be talking a little bit about the introduction of ultrasound and kind of get you all uh, familiar with the machine, the probes, and then we're going to actually do an actual like a module on the neck, the thyroid, and the eye, to kind of get you familiar with how to actually use it somewhat clinically. Um, we're gonna go over a lot of the physics, and we're gonna go over the actual the head and eye exam. We do have pre-recorded lectures that are a lot more detailed into the physics and a lot more detailed into the head and eye exam. So, after the session, or even before the session, anytime basically it's available to you. You took the session, or you want to learn more. Here's your QR code. Scan it. It links you to our website, and you can listen to both the physics section and the head, throat, thyroid, IJ, carotid section separately, and really go and delve into the details of it. What we're trying to do in this Zoom lecture is kind of prepare you for this session you're going to be having with us, um, uh, uh, essentially January 31st and February 7th. Okay, so just typical flow of the Palm ultrasound day. You should already kind of have some information from Palm, but just in case you don't, half of the students that are doing the ultrasound aspect of it first, you're gonna have room assignments. You're gonna go down to the sim center. There should be, your room assignments reposted, but please make yourself familiar even before you get there and what room you're supposed to be in. And you're gonna go ahead and go into that room at 1 p.m. You'll be met with a faculty member there. And you'll basically be doing the scans, and so we talk about today, until about 2:45. Then you have a break between 2:45 to 3 p.m., which you will go into your Palm session at 3 p.m. On the flip side, if you finish Palm, you all should be done with Palm at 2:45, and then you can basically do the ultrasound at 3 p.m. Go to your room assignments, faculty, et cetera, et cetera. So just in case you're not familiar, just so you're aware, we do scan on each other. This session will be pretty easy. It's going to be head and neck. But throughout the year, we're going to be scanning on each other. And so just kind of, it's a little odd at first, I think, but ultimately this is kind of how it's done universally when it comes to ultrasound teaching. And so just dress appropriately in future sessions. And I think ultimately maybe seems a little bit intimidating, but students tend to really enjoy the ultrasound aspect of this course and have a lot of fun. And if there's ever a time when it will be a little bit different, we'll let you know. But general expect to scan on each other. I don't know if
Yeah,
you have
it's
anything to
kind of
add.
logistically, yeah, no, logistically, it's a lot more challenging to get standardized patients for this. We do have a cumulative skills assessment at the very end of your ultrasound training, and for that, we get standardized patients. But for the general modules that we're going to be doing over the next year, it's going to be scanning on one another. So when we say dress appropriately, basically we mean wear gym clothes. So like we're going to be doing the knee at some point in the future. So for that, probably wearing shorts or loose pants would be appropriate. We're going to be doing echocardiography on one another several months from now. And again, for that, just wearing a loosely fitting shirt, not a shirt and tie for men and things along those lines, because it's hard and takes too much time. And you don't want to mess up your kind of nice clothes. So just wear gym clothes, loose fitting clothes that are easy to kind of like pull up and move. That way we can scan on one another and we can, get to the main issue, which is learning how to perform ultrasound. So that's the main tip there.
Yeah, and we will have these kind of Zoom sessions before every scanning day. And so I think you're going to have the opportunity to, learn what we're doing for that day every time, and and mentally prepare. So like Dr. Medak mentioned, when we are doing the knee, that'd be a good time to make sure you wear shorts. Um, quick little bit of just housekeeping. For our ultrasound aspect of Palm, attendance is mandatory. Essentially, you only have 2 sessions this year, January and May, and it makes it really hard for students to miss because to actually for us to book the sim center, have the machines and the faculty, there's a lot of logistics that go into it. So it's very, very challenging to redo these type of sessions. So we do require your full participation, and make sure you're showing up. We will be taking attendance, and excuse me. If for any reason you can't make it, please let us know ahead of time, and that way your absence can be appropriately excused. Um, that's for this year, Palm, and how we grade you. Basically, full attendance. Uh, just to kind of put it in your head, and I'm sure you're going to forget about it over the summer and early next year. But every year we do have an ultrasound style OSCE exam, that's done, usually, January, February, March or so. We're still working with Palm to get the full schedule for that, but there will be end of the year exam, and your grade for as MS2 will actually be based off that exam. Okay. So I think that's all the housekeeping stuff I have. So let's go ahead and get started. Let me just check something real fast. Okay. So the first part of the session, we're going to be talking a little bit about the actual machines, the hardware, the buttons, the knobs, the different modes, and how to actually obtain images, and a little bit about artifacts. Anthony, just so you know, I kind of moved some of the artifacts, I think, over to the specific sections because afterwards, instead of doing the belly like we normally do, we're going to do the neck. So it'll be different artifacts that are on the learning objectives. So this is really easy actually, but it's not a lot when it comes to an ultrasound machine. You basically have a computer, which can be your phone, and then you have an ultrasound probe, and put those two things together, and that's all you really need to create an image. And so if you look at something like this, can you see my mouse, Anthony? I'm
Yeah.
assuming you can. Great.
Yep.
And so
Yep.
yeah. So this is basically a computer and a screen. That's all this is, and there's different versions of these computers. Here's a Zonari. And here's the just a tablet, like I mentioned, like your phone. And then here's your actual transducers or your probes, and they essentially plug into your computer. And this is what sends the electrical signal out, to actually get the image. And if you want to learn a lot more about exactly how that works, that's when you can pop into that physics section and learn exactly how that's happening. But a component of an ultrasound machine is just the transducers and the computers. And you might have heard of this little gadget right here, but this is a butterfly, and essentially this is a more affordable transducer that works a little bit different than the traditional cart-based machines that we have in our sim center, and it plugs directly into your phone. So here's your transducer, and your phone's your power source and your image, and you got yourself a portable ultrasound machine. The transducers, though, sans the butterfly, which works a little bit differently, like I was alluding to, the transducers, though, they do have their own internal physics. And this is something you should know, is some of the transducers, mainly the linear probe, have what we call a high frequency wavelength. And so the wavelengths are very short, and there's a lot of frequency, as you can see. And so what's nice about these is you get a lot of resolution and you get a lot of detail. And the other transducers, the phased array, also known as the cardiac, and the curvilinear, they're the lower frequency transducers. And so they go a lot further, but you can see there's a lot of missing resolution. And so the benefit of this one is it's pretty shallow, but it gives you good resolution. The benefit of this one is that it gives you better depth, but at the risk of resolution. And I don't know if there's anything else to add to that, but that's essentially the two big ones. And so when you're selecting the ultrasound probes, you want to kind of decide, am I going for something that's relatively shallow? And in which case, and then I don't know about you, Anthony, but I consider shallow 4 or 5 centimeters, or less. So if I'm looking at anything 4 or 5 centimeters, you want to grab the linear transducer. it looks like this. And that first number on there actually tells you the frequency. It tells you it's a higher frequency probe. And you'll see it on the other transducers. They'll say like 5 or 6. And this one says 10. Some of them say 11 or 12. But that's a higher frequency transducer. And if you say you're looking at the neck like we are going to today, you're going to want to use that high frequency transducer. So today when you're scanning, you're going to use a higher frequency transducer. But before you really get started, also grab that low frequency transducer, look at the same neck anatomy with it, and you'll realize how quickly you lose all of that resolution you have. And then in the future, whenever you're doing anything in the body, like the chest or abdomen, you want to get that low frequency transducer, especially if you want to go beyond 5 centimeters. And so this is kind of what a linear probe looks like. The markings are kind of cut off here, but this is only, a few centimeters deep. But you can see this longitudinally, you can see tendons, you can see muscle really well. You get a lot better anatomy. And here's the contrary, the phased array, lower frequency, goes a lot deeper, and gives you a lot better a lot less of a resolution, but just essentially you can actually penetrate beyond 5 centimeters and still see the picture.
And just to piggyback on what Dr. Singh is saying, I mean, these two probes, you can just think of them as different tools. And so, depending on what you want to look at, you're going to want to use the right tool. If you're going to look at a superficial structure like MSK, musculoskeletal stuff, nerves, vasculature, or you're doing procedure guidance, you're going to want to use the linear high frequency transducer. If you're going to do something in the abdomen or you're going to do something cardiac where you're going to need deeper penetration into the tissues, then you're going to want to use something like the phased array. And there are many, many, many variations of these two probes, but for the most part, in the sim center and during your ultrasound training, we're going to essentially have these two tools to work with. But just keep in mind that as you go through your medical training and perhaps you end up being an interventional radiologist or a cardiologist or a urologist, there are different tools that are very, very specific that go much beyond these two. These are just kind of, two broad categories, and there are many others that are variations of these as well.
Yeah, and it's well said. And like Dr. Medak mentioned, there are so many varieties of these type of tools. But if you understand the concept of frequency and how that relates to resolution, and a high frequency probe gives you better resolution, you're gonna be able to, go into any scenario and know what tool to grab.
Exactly. Exactly.
So here's an idea of the phased array probe. Previously, like I mentioned, we were about 5 centimeters or so deep. And now we're almost 10 centimeters deep. And you can see, here's actually the liver, here's the aorta and long axis. You can see it kind of moving. You would not get any of this detail with a linear probe, because you would basically end right over here. You would see the liver parenchyma really well, and you would see the anatomy of the liver just superficially very well, but all this would be lost to you. It's actually a really beautiful picture. You can actually see the celiac trunk coming off right there. And here's the superior mesenteric artery as well coming off right there. It's really nice. You don't have to worry about that just yet.
Just yet.
It'll come up though. And like we mentioned, without going too much into it, there are other transducers. These are the other two commonly ones you will encounter most likely. This is the curvilinear transducer, and essentially it's analogous to that same phased array. It's also a low frequency transducer. And this is the endocavitary transducer, and similarly, it's analogous to the linear probe, and it's actually a high frequency transducer. Okay, there are a lot of buttons on an ultrasound machine, but a lot of them are somewhat most of them are somewhat intuitive, and we don't expect you to know where every button is on every machine, but we do expect you to know what the buttons do. I can tell you that, I've worked clinically at many sites, and I've come across many different ultrasound machines. I've taught courses internationally, and we all have in the ultrasound world. But you can come to, a different country, and they have a totally different brand you never heard of, and you've never seen this machine before. But if you understand this basic concept, it takes about 5 minutes, and you can learn it. I don't know. Maybe another analogy would be, driving a car. You might not have driven every type of car, but you know generally where the gas pedal is and the brake is and how the steering works. And it might take you a few minutes in the parking lot, and once you get it, you can drive any car. And this is
Yeah, and of
very
course,
similar.
and yeah, totally. And keep in mind as well that, we intentionally down in the simulation center and at the medical school have many different brands of ultrasound systems, and they're all going to have a slightly different user interface. But that's where your small group instructor is going to come into play because they have a lot more experience with these systems. And so when there comes a question of how to adjust the gain or how to go into kind of color Doppler mode, et cetera, your instructors will be able to help you with all that. And when it comes time for that ultrasound OSCE at the end in the winter of the MS2 year, how to know what buttons to push is not really part of the assessment itself. If you want to do something on the system and you don't know what button to push, your instructor's there to help you out, and that's not a testable item. So don't worry about that. You just have to understand the concepts, like Dr. Singh was saying.
Right. You have to know that you want more gain, but you don't have to understand exactly where in the machine the gain button is found. Um, Going back to here, because they're all over the place. Here's different machines, but you can see the freeze, how to save an image, calculations, and on some of the touch screens, it's very different. It's all touch screen, but the buttons do all the same thing on all the machines. Um, to actually scan, you're gonna first pick your probe, and so again, it's like picking your tool, right? What are you trying to do? So today, when we're doing the neck, you're going to want to use a linear probe, the high frequency tool, to look at all those things that are relatively superficial. Then you want to actually have your exam preset. So this is always a good idea to, before you scan, once you select your probe, you want to actually tell the machine what kind of exam you're doing. So if you're doing an abdomen, you want to tell it you're doing an abdomen. If you're doing OB, you want to do OB. There's a lot of internal calculations in the machine that, that, to be honest, are beyond, my knowledge base. But the machine is internally setting it up to get that best possible exam for what you're trying to do. Gain is a very important function. So here's an image that's low gain, here's an image that's a high gain, and here's an image that's essentially well gained for this scan. And this is not a complicated concept. This is basically like the brightness of your computer, right? You can turn your brightness up, you can turn your brightness down. And let's see, and different machines. So here, this is the gain knob here. Sometimes you can just, increase the gain more um, superficially or deeper. And or this is your overall gain. And on this machine, essentially, it's the brightness bar right here. Auto gain's a nice feature. It's when you're first starting an exam, you don't like your image. A lot of students will hit auto gain first just to go back to what the default should be for that exam. Depth. Depth is a little bit of a trickier concept, because I did mention that depth is limited by the machine you use, but you can change the depth. Um, For the linear probe, you usually do max out around 5 centimeters or so. And for the phased array or curvilinear probe, those deeper probes, you can, increase your depth a lot further. Um, the best way to explain this is when you're trying to scan, you essentially, your point of interest, your image, you want to kind of have it in the center of your screen. This is where your image will be the most clear for you. And so if you're looking at a heart and, the heart's way up here and all this is kind of lost space, you actually want to decrease your depth and the heart kind of fall within this kind of Goldilocks zone of the image, what we call the focal point. Um, and obviously, if your heart's way, farther, you want to actually decrease your depth, and the heart will move into that focal zone. But your point of interest should be in the center of your image. There you go. Nice animations, Anthony. Um, and so those are pretty basic concepts. Now this is a lot more ultrasound specific, and now we're actually getting into some of the ultrasound terminology. There are different modes of scanning, and we do expect you to know these different modes. Um, Anthony, do we cover M mode often in this course? I we
uh, in pulmonary, perhaps.
Yeah, yeah. But these are the general, universally accepted modes of scanning. The first mode is 2D mode, also known as B mode. But basically, this is just your your general grayscale scanning. This is what you're doing all the time. Because when you hit the image and you're looking at everything move around and you're scanning, you are in 2D mode. Then there's color mode, which is actually putting color onto your picture. And today you will be doing all these modes. Then there's Doppler mode, which I always found to be poorly named because all of this is Doppler. But
Yeah.
this is color Doppler, and this is known as pulse wave Doppler. And what this allows you to do is it puts a little sampling gate. So not only can you see color with, which tells you directionality of flow, this will actually give you the velocity of the flow. And finally, probably the one that's the least intuitive to understand is M mode, which is motion mode. And that's what you're doing is you're basically when you hit motion mode, it essentially activates one beam down the center of your probe, and when you hit it again, it graphs all the motion along that beam over a period of time. So you'll see x-axis of time and y-axis of motion along that beam. And we'll talk a lot
And
more.
that can,
Go ahead.
yeah, that can be very helpful when you're, for example, if you start to get more sophisticated with looking at the heart, for example, and doing echocardiography, you can measure how much a valve is opening or closing. Or, for example, when we do lung ultrasound, you can look at the amount of sliding of the pleura as well. So it's a kind of a more niche mode. It's not something you're going to use a lot, and we'll talk more about it as we go through your ultrasound curriculum.
Right. And so, yeah, well said in the sense that as we go through, all these modes are going to come back up over and over again, and we'll go a lot more into detail. But knowing these modes exist and playing with them today, I think will help you. But we will actually demonstrate when that time comes of how to actually use these modes in certain situations. So this is your B mode slash 2D mode, just your general picture. Here's your liver, here's your kidney. That's why they call it a kidney bean. It literally looks like a little bean here. And I'm glad we have it right here so we can demonstrate this. This is your M mode, what we talked about. So if we hit M mode, there's a little line that's coming through here. And what the machine will do, it'll basically start graphing. So here's time on the x-axis. And then your y-axis essentially is that line. And so you see how it's really bright up here? Well, that's all that brightness right here. And then you see how there's a little bright line right here. This is your interverticular septum. Well, that interverticular septum is right here. And so as our heart is contracting, that septum's going to go down and go up, go down and go up. And you can see that motion over time of that septum, collapsing and opening, collapsing and opening. And then this little line right here, this is your mitral valve. And this is going to come up and touch that septum and come down, come up and touch that septum and come down. And you can see that going as well. So it's kind of neat that you would know that when this septum is when this mitral valve is touching that septum, like in this first picture here, the mitral valve is touching the septum's coming down, the mitral valve's coming up, and they're nearly touching each other. You know that is essentially diastole because that mitral valve is open and blood is flowing into the left ventricle. And then when that mitral valve goes away from the septum, so basically it's coming down right here, it's closing off the left atrium. The blood can go this way, and now you're going to be in systole. And that's a great use of M mode. I feel like a favorite mode of students is putting color Doppler on and color flow. And so it tells you the direction of the flow. You can gauge some level of velocity, but it doesn't give you the number. So if you see two vessels, and so to give you an idea, here's my probe. Actually, my little blur makes it harder, doesn't it? But here's my probe. And so if I angle it this way and I have fluid going right at my probe, the imagine the probe is your ears and the fluid is an ambulance, right? You can hear the ambulance coming closer to your probe. And as the ambulance passes up the probe and is going away, you can hear the ambulance going further away. So the machine's doing the same thing. It's picking up that the blood is going towards itself or it's going away from itself. And it basically puts a color on. So if you see red on ultrasound, it doesn't mean artery. It actually just means the blood is going towards the probe. And if you see blue, it doesn't mean vein. It means that the blood is going away from the probe.
That's a super important concept. It's a common kind of pitfall that new learners with ultrasound will kind of fall into, and that is just thinking that blue and red correlates with arterial or venous. It definitely does not. The blue and red simply correlates to directionality. And if you're a mnemonic type person, you can remember BART, B-A-R-T. Blue is away, red is towards. If you're not a mnemonic person, if you look at that screen the image that Dr. Singh has on his screen, on the top left of it, you can see there's kind of various shades of orange, red, and blue. That's a color flow map. And generally, by default, red will be on the top and blue will be on the bottom. And when that's the case, whatever color is on the top of that color flow map is going to be towards the transducer, and whatever color is on the bottom is going to be away from. So again, the convention here is followed, and that's going to be the vast majority of the time. Blue is flow away from the probe, red is flow towards the probe. And we'll demonstrate that when we look at the great vessels of the neck, as we look into more detail and discuss the thyroid content of this module later in the slideshow.
Yeah, excellent. Yeah, so today when we scan the neck, we we're going to do that a little bit and have some fun with it. Have the colors in the vessels flip, and
Yeah.
and with your instructors, then and that it'll really help click that concept. Pulse wave Doppler, this is like I said, this is actually giving you the actual speed. So, the red is towards or blue is away. But if you actually put a sampling gate, it'll actually give you how fast it is going towards the probe if it's a positive deflection, or how fast it's going away from the probe if it's a negative deflection. A lot of the machines,
Go ahead, good.
on the machines, often it'll say Doppler, we mentioned earlier, but this is just so you know, this is pulse wave Doppler, but sometimes you'll see it as just Doppler. What are we going to say?
Yeah. The horizontal axis is time, the vertical axis is velocity. And here, like Dr. Singh was saying, you can be more quantitative and look at the exact velocity of the flow as opposed to just using color. You can get some idea of what is faster or slower, but you're not really as quantitative about it. And of course, if, for example, this split screen was such that, or excuse me, the probe position was such that flow was going away from the transducer, then when you do pulse wave, that large positive deflection that you see recurring again and again and again would be below the baseline. That would indicate negative flow or flow away from the transducer. So whereas in color flow, you're talking in red and blue, in pulse wave Doppler, if the complex is above the baseline, that's flow towards the transducer. And if it's negative, that's flow away from the transducer. In this case, the waveform is positive or towards the transducer.
Yeah. And it correlates with the fact that it's red up here. And as mentioned,
Right.
this is the top color. And you can see what kind of range of sampling it's doing. Um, so to actually, start getting the images, this is a very important concept. You're gonna see these little notches on your probes, and essentially those notches are corresponding to some kind of indicator on the screen. And so in this situation, this little notch right here is corresponding to that M on this probe. Um, I don't know, Anthony, I always have a hard time verbally explaining this concept, and it's something that clicks when you actually start scanning. But if so, imagine your probe is basically drawn right up here, and the notch is corresponding to this notch. That way, when you scan your probe towards the left, the screen moves left, and when you scan your probe away from the notch, the screen moves away from that notch.
Yeah, exactly. Most of the time, people that do ultrasound use the term screen marker dot, which in this case would be that little M logo, and probe marker dot, which would be that little nubbin that Dr. Singh is pointing to. And that's just simply so that you know which way is anterior or posterior or medial or lateral, depending on what plane you're imaging the patient. And by convention, and we're going to talk about this in a minute, you're going to want to orient the probe marker dot towards the patient's right or towards their head, depending on what plane you're imaging the patient. And that is the convention the world over. So if you're reading a journal of some research that's done in Europe or anywhere the world over, the conventions are the same. So that way, the way you're doing the scan in San Diego is going to be the same way it's done everywhere. That way, we're all speaking the same language when we're looking at these types of ultrasound images.
All right, excellent. Just for a fun little side tour, Anthony, what do you think the over under is that I failed to save this video that we're making and the students never see it?
I hope you're wrong.
Yeah, this is their first one. And if you got that joke, I'm happy because that means that I didn't fail to not save it. Artifacts, this is important. So this is basically things that aren't really there, but the machine will show you are there. Throughout the course, we're going to talk about artifacts. Historically, in this first lecture, we focused a lot on artifacts, but the way we combined it with the new module, including head and neck, we're going to shift a little bit away and talk more about the head and neck today. But just know that we'll sprinkle more artifact knowledge throughout the course. But artifacts are things that are not really there, but the machine's picking up on because the machine has some internal limitations. For example, this is essentially a person's abdomen, and you can't see anything in the abdomen. It's all black. But we know the person's abdomen is full of bowel, it's full of stool, it's full of air, but you can't see any of that. And the reason being is that you're getting this artifact up top. You're getting this kind of hyper quick bright lines up here that are causing all of the shadowing and not allowing a signal to go through. And this is happening because as the sound waves hit the bowel gas of the abdomen, they all scatter and there's no return signal to the machine. It's equivalent of speaking in space, right? The machine doesn't hear any return signal. And therefore, it just basically blacks out the rest of the image for you. And there's no information to be gained. And you
Yeah.
can deal with the artifacts by pushing the bowel gas out of the way.
Yeah. Just to piggyback on that, like Dr. Singh is saying, and I like that analogy of trying to, hear something in space. The ultrasound energy or the ultrasound, the whole principle of diagnostic ultrasound is about basically shooting sound energy into the tissues. The sound energy bounces off of stuff and it rings back to your transducer, which is both a speaker emanating that sound wave and a microphone listening for the return echo. And that's why, for example, when we image the heart, it's called echocardiography because you're bouncing a sound energy, a wave into the tissues and it returns. But that sound energy needs a medium to travel through, and it doesn't like to travel through air. And so as a result, what you're getting on the left side of the screen here with bowel gas is basically nothing. All you're seeing is a bunch of scatter because that sound energy doesn't have a proper medium to propagate through. And that's why one of the things I say a lot over the course of this course when I'm teaching in small groups is that ultrasound energy, sound waves, have two main enemies. One is air and the other is bone. And that's why on this particular example, you're seeing two manifestations of how sound energy can be an issue around air or around bone. And around bone, there's another type of artifact that we're going to talk about now.
Right. And so this is basically the artifact around bone. So if you look at this picture right here, right, you can clearly see some stuff. So this is the liver, here's the kidney, but you have this small window that you can see through, and right and left of this image, there's a lot of shadowing and darkness. So we call this rib shadowing. And what's happening is that the sound wave is hitting these ribs and bouncing off, hitting this ribs, bouncing off. The rib is dense. It's not allowing the sound to go through, and the machine blackens out the rest of the image. Giving you a very similar picture here where you can't have any signal, but for a very different reason. If this is talking about, no sound in space, this is basically trying to give sound while there's a wall in front of you and you can't hear on the other side of this wall. And so same thing, it's kind of blacking it out. There could be pathology here, but you would never see it because of this blackness right here. So this isn't real. This is just shadowing because the signal can't go through.
Exactly.
So yeah, the air is the enemy of ultrasound, and dense things like bone are the enemy of ultrasound. But as you understand that concept, you start using it to your advantage because dense things like gallstones will also cause shadowing. And then you can look at a gallbladder, and if you see something dense inside of it causing shadowing, you can say, aha, that must be a stone. It's calcified, it's dense, and I'm getting shadowing. So we're gonna jump soon into actually talking about the eyes and the throat exam soon. But the goals for this part of the scanning is to become familiar with the buttons on the machine, become familiar with the different probes and their frequencies and what that means, and become familiar with the different modes of scanning. And we'll note certain artifacts. And so today we will actually be noticing some of the dense artifact from something that's relatively firm, which is the trachea, and also some air artifact because behind the trachea is also air. And so essentially you have no information when you scan the trachea. So we'll notice that artifact today. We'll talk about these scanning modes, and we'll actually demonstrate this when we get into the exam. So this is the thyroid module next, or the head, the neck, and the eye module. So here you have essentially a picture of what we're scanning. So you have your sternocleidomastoid, which actually is more anterior, and deep to that, you essentially get your internal jugular vein and your carotid. And traditionally, it's thought that the carotid is running medial and the IG is running lateral. I don't know about you, Anthony, but I'll see them crisscross over each other. Maybe not crisscross, but I will see them sitting on top of each other.
Absolutely. That's why it's so nice to be able to see that anatomy dynamically with the ultrasound. Yeah, totally agree.
And here's a cross section of the same picture. Really nice done. Anthony, who did these pictures? If I remember correctly, you told me a student did these a while ago for you.
Yeah, yeah. An alumni of the program was an excellent artist, so we gave them a little stipend to do these medical illustrations. They're really nice.
Yeah, these are beautiful. And so here's cross section, but here you go. Here's your IJ right here. Here's your carotid. Here's your thyroid and your trachea. And deep to the trachea is your esophagus, but you'll never see it because of the artifacts produced by the trachea, which are the cartilage of the trachea and the fact that the trachea is filled all with air. Um, I hope that, at this point, you kind of, you're going to say, I want to grab the linear probe. I want to grab the high frequency probe because this is a superficial structure. And essentially, we start scanning. Go ahead and take your patient and, have them look towards one side so you can really open up that neck. By patient, meaning your co-students. And then, match up your marker dot on the screen. And really important to practice that today. And we will, but you want to know where your marker dot is on the probe and where your marker dot is on the screen. And I can chime in anytime you see fit as we go through this. But here's essentially your image. So one thing to remember, and this is a key concept of ultrasound, is what's on top of the screen is basically what's touching the probe. And so this is the patient's skin up here because that's where the probe is touching their neck, right here. And as you go deeper and deeper and deeper, you're essentially further from the screen is on the bottom of the probe. And so here you can see the sternocleidomastoid muscle, and deep to that, here you can see your internal jugular vein. This would be on this side, depending on what the probe marker is. And then here's your carotid, and here's your thyroid right here.
And also, just one other thing to note at the top of this image on the top left, you can see a little letter Z. For this particular brand of ultrasound system, that's the screen dot. So again, that screen marker dot is going to correlate with the probe marker dot, which is only going to be on one side or the other of the footprint that comes into contact with the patient. So whenever you're getting ready to do the exam, if you're ever unsure where the probe marker dot is, once you have a glove on and you have some ultrasound coupling gel on the transducer, you can always just touch the probe on the side of the probe dot. That way you can make sure that you have it oriented correctly. You want to make sure that probe dot and the screen dot are in your mind linked up so you know which way is up, down, and medial, lateral, etc. on your patient.
Great. And then yeah, that's well said. And honestly, I can't even see the marker dots because the floating zoom buttons are in my way. But I'm assuming it's right here.
Yes, it's
Oh,
right there.
okay. And then here's the cross-sectional view. What you're looking at here's the thyroid, the carotid, the IJ. And when you do scan today, just I mentioned this earlier, but once you get this picture, just for funsies, go ahead and swap out the probe, put the phased array, and just see the difference and how that tool would not be appropriate for the scan.
It's
Uh,
quite striking. It'll be very impressive and quite different when you look at it.
um, there are some things that you can do to kind of go ahead and make this IJ bigger. You can put them in Trendelenburg, which is going to obviously pool the blood into the head, and then you'll see the IJ become bigger. And we'll practice that today. Um, you can also Valsalva. So just going back to the previous slide, you can have your fellow students hold their breath against a closed glottis and basically bear down, and then that'll really make the IJ get bigger. And that's one way you can tell the internal jugular vein from the carotid. You can also compress, and you can actually see the IJ compressing, and the carotid won't. And so practice all those things in that B mode, scan up and down, play with your depth, play with your gain, get familiar with those buttons. And when you feel comfortable with that, go ahead and start scanning in different modes. And here's your color mode. Here's your B mode. No, sorry, your color mode and your B mode. So your B mode, your general grayscale, and this is your color mode. When you put the color mode on, you can see two different colors. And so Anthony, I'll challenge you to talk them through this and discuss which if they think the probe indicator, if the probe is facing a little bit down towards the heart, or if they think the probe is facing up towards the head, knowing that this is your vein and this is your artery.
Yeah, okay. So right now you're getting a transverse view across the neck. You can see towards the left of the screen, you can see the thyroid gland on the far left, yep, right over there, and that indicates the midline. And then you have those two vascular structures that are abutting one another. One is the carotid artery, one is the internal jugular vein. Just from experience and just basically from the shape and the pulsatility of it, I can tell you that the red vessel in this case is indeed the artery, and the blue is the vein. But that's just in this particular instance because you're going to basically have the angle of the probe situated such that the venous flow, which is going to be going draining the head and the neck down towards the chest, is going to be going in that direction, and the arterial flow going in the opposite direction is going to be going from the chest up towards the brain. And so, depending on which way you have the probe head angled, you can make the vessel, the internal jugular vein, for example, look blue. But by simply changing the angle of your transducer in the opposite direction, you can make that same vessel appear red on color flow, because the red and the blue is directionality of flow relative towards the transducer. And that's very important. You can't just necessarily assume that the blue is the vein. If you angle the transducer in the opposite direction, that internal jugular vein will now appear red and the carotid artery will appear blue. And that's something that you will be practicing today in your session with your small group instructor.
So in this situation, I would wager that relatively speaking, that they have a little bit tilted down towards the heart because the carotid is red and it's pumping towards the probe, and the blue is away and draining from the head down to the heart. And essentially, if they were to change the angle of this probe and angle it a little bit more towards the head, now the the vein is draining towards the probe and it'll become red,
Right.
and the carotid is
Exactly.
pumping up towards the head and it'll become blue.
Right. Exactly. Just by changing that angle.
Yep. And then now they've basically taken these pictures and they've gone long axis on them. So once you put in center of your probe, they've basically gone long axis. And you can do this is the pulse wave Doppler, and you can do it in short or long, but just so this is a different demonstration of a different kind of picture. This is longitudinal over the vessels. And if you can't tell which one's which, they're basically taking the sampling gate and putting it over the carotid and noticing there is this pulsatility, and here they're putting it over the vein, I'm assuming, and there's a little bit of pulsatility, which is actually probably just um, the pressure transmitting from the carotid. But you can see in general, the mean of this is kind of a flat line, and this is more of a venous hum.
Yep.
And compression, you basically compressing the IJ compared to the carotid.
So basically, what we're just
Go ahead.
demonstrating there is that there's a couple different ways you can differentiate a vessel being arterial or venous. Kind of the lowest tech and most intuitive way to do it is push on it. If it's a venous structure, again, in the normal scenario when you don't have a blood clot, etc., if you push on a venous structure, it's going to easily collapse, as you can see in this video, and the arterial structure adjacent to it will not. If you're uncertain or you're concerned for a thrombus or a blood clot, etc., then you can use pulse wave Doppler and look at the waveforms. But in general, when you just want to differentiate artery versus vein, if there's no pathology ongoing, just apply gentle pressure with your probe and the venous structure will easily collapse and the adjacent arterial structure will not.
Great. Um, and then here's, essentially they're trying to kind of do some compression and they're not moving. And you can see there's actually, here's pathology. There's a big clot in the IJ. There's no compression. You can't compress it because there's something physically there that won't let you compress. And this is how we scan for a deep venous thrombosis or a DVT.
One little caveat that's a little bit of a bummer is that you won't necessarily always see the thrombus. You might have an acute thrombus that is not echogenic, so you don't actually see the clot within the lumen as you do in this example. But when you try to compress it, it won't compress because there's just a clot in the lumen that you can't yet visualize.
Um, Scanning the next item we're going to scan is the thyroid, and so we've been kind of mentioning it the whole time already, but essentially it's a bit more medial from either side to get to the thyroid. And when you're scanning the thyroid, you're clinically, you can look for thyroid calcifications, look for masses, look for cystic lesions, and these are pretty commonly found. They're not always concerning. There can be there's some variations between individuals, but you can see these things pretty readily on ultrasound. And when we will be using today to demonstrate how to actually measure a thyroid dimension and calculating volume. And this is if you have a large thyroid, you can actually see physically measure it and see that it's enlarged compared to a standard measurement. And here's some normal values. You don't have to memorize for the purpose of this course what a normal value looks like, but just to give you some general reference. Okay, so we're scanning from lateral to medial. So here's the IJ, the carotid, the sternocleidomastoid, and you can see this is the thyroid gland-like tissue. And it's interesting. I feel like no matter wherever I see endocrine glands with ultrasound, they always kind of, Anthony, have this homogeneous kind of
Yeah.
tissue appearance on ultrasound.
Yep. It should be homogeneous. And when it's not, and by that we mean obviously all being the same, if there's a little focal area that is more echogenic or basically fluid filled, then that raises the question of could there be pathology, a cyst, an infection, et cetera. But it should be homogeneous, exactly.
And so when you scan your thyroid, start at the level of the kind of the mandible there and scan down. And generally, I start seeing it a lot more lower by the clavicle.
Yeah.
And this is basically sliding down. Fanning is kind of these movements right here. Rocking is this movement, compression, and then rotation. But now we're just kind of fanning down, and you can see that as we're fanning, the thyroid's getting more and more in view. So you can measure the width of the thyroid. Whenever you want to do any kind of measurements, you want to freeze the image first. But so this is, again, what's on top of the screen is what's touching the probe. And so this is your depth right here, your anterior and your posterior. And here's your width, right? Your right and left. So this is an example of measuring the width. Freeze the image and measure the width. And now you have one of your three dimensions if you were to get volume. You can basically, in that same picture, go ahead and get the depth, the anterior and posterior volume. And finally, to get the third dimension, now we've been doing, a two-dimensional scan, but these organs are three-dimensional. So you have to go ahead and unfreeze your image and get that third dimension. So you go ahead and go long axis on it. And when you do that, you realize that this dimension, the anterior posterior, you already have that number from the previous picture. So now you want to measure basically left to right, which in this case, if the probe indicator is towards the head, so this is basically going to be the head and the feet, cephalad and caudal. Going back, this happens a lot. Students will say, I don't see the entire thyroid here. There are ways to kind of mitigate that. That's okay. For our purposes, we want you to really understand um, what this means by measuring and how to get a volume, because this is universal across everything. We don't, it doesn't matter to us that you get the exact thyroid volume, but just understand the concept. And you'll know when it's way bigger. If you see this anterior posterior and you see this a lot bigger, then you might want to actually find the exact volume clinically. But it's mixed. It's more important to us that you understand the concept of volume measurement and what's doing.
Yeah, and what Dr. Singh is alluding to there is that if technically you look at this image, you should be able to see a discrete pole, a superior pole, which would be on the same side as that little Z logo on the left of our image here. That's going to be where the superior aspect of the thyroid gland terminates. But we don't see that termination. We still see thyroid gland that's essentially going beyond the screen. And on the opposite side of the image would be the inferior pole. but we don't actually see either of the poles because this transducer and this setup is not optimized for calculating thyroid volumes. Because again, that's one of those specialty tools that we don't necessarily have at our disposal. But the concept is the same. You need to take some measurements in the transverse plane of the neck, then you need to turn longitudinal and take measurements in the craniocaudal orientation. And in this instance, like Dr. Singh was saying, it's good enough to measure the two extremes, but understand that technically we should be extending above and see actually where the superior and inferior poles lie to put those calipers to get a more precise measurement. But the concept is the same, and that's the gist of what we're trying to get across.
Yeah. And just to critique our own images, this is far too much depth for this picture. We'd want this picture to be right about here.
Right.
And finally, we're going to go over ocular ultrasounds. Just in the interest of time, here's relative ocular anatomy, which we'll cover when we look at the ultrasound. Um, I like this slide a lot because essentially you can just point out all, the cornea, the anterior chamber, the iris, the pupil, the lens, the vitreous body here, and the contours of the retina in the bottom and the optic nerve. And the reason why I like this slide and the reason why we talk about ocular ultrasound is because we talked about the fact that air and bone are the enemy of ultrasound, and fluid is a nice conduit for ultrasound images. And so this is a big fluid-filled structure. So the skin is very thin. So you can literally put your probe right on top of it, floating in an abundant amount of gel, so you're not putting pressure. And you essentially can see the same contours, the same picture, and the exact same thing: the cornea, the anterior chamber, the iris, the pupil, the lens, the vitreous body, the retina right here, and the optic nerve and sheath very clearly. Again, you want to use a linear probe. You want to use, a fair amount of gel. I like this video right here.
Yeah, and step one is make sure your patient has their eye closed.
Yeah, fair enough. And honestly, like if you think you've used enough gel at that point, I usually double it, and that's how much gel I use. And the reason being is you don't want to put pressure on the eye, and you want to float the probe in the gel because it's uncomfortable to have pressure on the eye. And so, as you scan, and your instructor will teach these little fine motor movements, but always go, tripod, so have part of your hand on the person's body and hold the probe like a pencil. And so this one it's really important because if you want to hold your pinky on their nose or on their forehead and float the probe like this, you put pressure here on the forehead and the probe just floats on their into the gel. Scan in both planes. So here's the short axis plane scanning up and scanning down, and then you go long axis scanning medial and scanning lateral. And you get something like this. And then today we'll be, noticing all the anatomy, but you can see the iris in place. And as you scan, you get a little bit of like a hole in the iris. That's your pupil, the lens, the anterior chamber right here, the vitreous body. This is the retina. And occasionally, as you scan through, you actually will see the optic nerve coming into view. This, without going too clinically, this is a really, really important exam, especially for ER physicians and ophthalmologists, obviously. People come in with floaters, vision loss, and very quickly you can see if there's any kind of damage in the vitreous body, if the lens is dislocated, if you can see if the optic nerve is swollen, or you can see if the retina has popped off the back and it's a retinal detachment, which is a pretty common emergency that people get.
Yeah, and one thing I'll point out to you too as well, if you just go back that for just 1 second on that previous slide, is that you can see that towards the bottom of the image, you can see the optic nerve is black. And the reason it's black, or to use ultrasound terminology, hypoechoic, or you could also say anechoic, free of echo, is because that optic nerve, being part of the central nervous system, is bathed in cerebrospinal fluid. And that spinal fluid is basically water, and anything that is water-based, whether that be blood or urine or a pleural effusion, etc., is going to look black. So you can see that towards part of that image, you can see the optic nerve is anechoic, and the reason is because it's bathed in CSF. And so that is a tip off that that's the optic nerve going into the back of the eye.
Oh, Anthony, I'm so glad we're doing this lecture. Like, I always learned something from you. I didn't realize that's why it was anechoic. I always just thought that there was some shadowing coming off where it's hitting the optic nerve tissue. But that makes a lot of sense. Thank you for that.
Yeah, sure. Hmm.
And so, looking at a normal one, here you might not know what's wrong, but you can clearly tell something is wrong, right? As you get further, in your careers and depending on what you do, you'll be able to tell exactly what's wrong. But this is actually a retinal detachment. This is a retina that's come off from the back and is floating in the vitreous body. Without getting too much into exactly, tethering and stuff like this, the idea is that it doesn't once you learn what normal is, you'll start very quickly finding out what's abnormal. And initially, when you first start learning, you might not be able to define exactly what's wrong, but you start picking up pathology. And with practice, you start actually, giving a name to that pathology. But this is a retinal detachment. So the goals, we talked about this, is becoming familiar with the machines and the probe, but now actually scanning the relevant anatomy we talked about today, noticing that tracheal artifact, scanning the ocular, the carotid, thyroid, and IJ. And that's what you're going to be doing. There's not going to be any in-person lecture. I hope you all listened to this and enjoyed it. When you show up at 1 p.m., go to your scanning rooms. Instructors will be waiting, and you'll get the day started with them.
All right. Well, thanks very much, everybody. The bulk of the learning is actually getting into the small groups and scanning on one another. So hopefully this is a good primer and introduction, and we'll see you guys in the simulation center. Take care.
All right.
Thanks.